Good morning, everyone. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX, and we're delighted to invite you to another community conversation. Today is January 16th, and it is Martin Luther King holiday. We're delighted to have special guest here today. I'd like to, before we start, just acknowledge that we are all on the traditional lands of the First People wherever we sit. Seattle, Canada, here in Maui, you are elsewhere. And so we'd just like to honor with gratitude the original people, past and present. Also, I'd like to create this meeting as a safe space. And so what that means is that every voice is heard and will be respected. And we enter this space knowing that we all have different lived experiences and we recognize the potential for harm. And we are also committed to healing should harm occur. We're delighted to welcome Dr. Michelle Terry, who is attending physician and clinical professor at the Department of Pediatrics at the University of Washington. She's also the president of the King County Medical Society, among many other things, here in the Seattle area. And I'd like to invite Dr. Terry to give the labor acknowledgement.
Good morning, everyone. Thank you so much for joining, and I am so delighted to be here. I wanted to offer a labor acknowledgement, especially in honor of the MLK Day. Enslaved people from Africa and their descendants suffered the horrors of the transatlantic trafficking of their people, chattel slavery, and its subsequent reformulation into contemporary modes of structural racism, including Jim Crow segregation and the new Jim Crow of economic exclusion, and health disparities. Yet the labor of African Americans has been essential to the physical and economic infrastructure of the United States. And so I personally am indebted to the labor of unsung professional innovation across many disciplines and to the sacrifices towards liberation from which all peoples have benefited.
Thank you, Dr. Terry. And I'll just invite you in the future, just sit a little bit closer to the microphone. So,
Okay.
yeah, we're really happy to have you here. This is a very special day and one that we're very excited to celebrate with you all today. So with that, as you all know, we all start the community conversation with a discussion about the latest on COVID. And here to give us that perspective is Dr. Dale Reisner. Dale?
Well, good morning, everyone, or those of you that might be already in afternoon. I am going to do just a little bit of data on the national and global, as I do typically, and do a deeper dive, and I've done this in the past, but into the racial differences of the COVID data. And I have another comparison. I've got a few new tricks for today, so you don't all get bored. New weekly cases are up. The data was refreshed yesterday, and because of the MLK Day today, will not be refreshed till tomorrow. But across the US, over 400,000 new cases daily. So we are still in the post-holiday peak. There is a new variant called XBB.1.5, and I'm reading that because I don't want to remember those numbers. It is an Omicron variant, as have been pretty much everything since the onset of Omicron, and as Delta waned. Pretty much not seeing Delta at all now. The total cases in the US are over 100 million. And the total deaths are almost 1.1 million. Deaths weekly right now from COVID are running pretty close to 4,000 across the US, so it's not benign. And lots of hospitalizations, although not to the degree that we had with really having no ICU availability. To compare with global, the cases are 667 million and the deaths are 6.7 million. So when you look at both the data from the US and from globally, the death rate is about 1% from COVID. So that's including people that are vaccinated, those are not, and different populations. So I'll talk a little bit about the different populations. To put that into context with the recent flu we've had, the deaths from flu are 0.5, almost 0.6%. So almost half.
0.05. Okay, so about half.
Right. Yeah. 0.5. So that's 0.5%, right? So that is half of what we're seeing. The majority of those are in the 65 and older population. So about 80% of those deaths. The flu data is a little softer in terms of validity because they're still trying to do a better job collecting the childhood data from flu. We know there have been deaths, but they don't have any data that would suggest, that they're presenting that would suggest that. So I think we'll see more, probably a little bit more solid data in the next few months on flu for this season. And those data. Yeah.
Last month that we had this community conversation, we know that our pediatric hospitals were just bulging over full because of the flu and RSV and COVID. What's the picture look like there?
So that has, because RSV started, Michelle is a pediatrician, so she's an expert in this, but because it started earlier in the summer than it normally would, that peaked probably late August. And July and August were the worst months for RSV, some into September, and then flu started up and overlapped that. And flu definitely has been the leading cause of pediatric admissions. I think hospitals are still, the pediatric units are still pretty full, probably not as dire as what we had when we had both RSV and flu running at the same time. And then typically those admitted who get sick are kids that have underlying illnesses, particularly asthma. So yeah, that is, we're still understaffed in many parts of the country for nursing staff and other hospital staff. And that is something that's not going to get fixed quickly. And so I think we certainly, in Washington State, we have a whole regional organization that helps to direct really sick kids if needed. And I've talked to them recently about a subset of early deliveries in my specialty area. So not everywhere in the country is like that, and people need to, check.
Oh.
Percent. They will have the flu variation that they can build the next year's vaccine from, which we did not have over the past 2 years. So the one other thing I wanted to spend just a little bit of time with is talking about how the COVID cases break down by race, ethnicity. And we've talked about this before, and it's not particularly different now. But if you look at, this was looking at about 94 million of those 101 million cases I mentioned in the US. So not bad ascertainment. 66% race and ethnicity was known. So not all. When you look at the number of cases, based on the percent of population, the Hispanic and Latino are much higher in terms of infection rates, but they're lower than their population when it comes to mortality or deaths from COVID. American Indian, Alaska Native, again, very small group, but they have a higher both both infection rate and death rate than their population, percentage of population in the US. Asian population, lower cases and way lower, they have the lowest death rate of any of the race ethnicity subsets that we have available to us. Black, non-Hispanic is the way they categorize Black in this data. The case rate now is about the same as their population percentage. Their death rate is a slightly higher. And I know Michelle will be talking about some of these things, not specific to COVID necessarily, but the disparities in healthcare outcomes. And then for the white population, the case rate has dropped lower than our percentage in the US population. And the death rate is a little higher. And again, this is mostly in the elderly and those who are immunosuppressed. So that's not really different than what we had before, but I think this is a good day for us to be remembering that. And the one other thing I was going to mention that is newer, before we get Michelle spending the majority of the rest of the program, is on long COVID. So we've talked about long COVID in the past and not really knowing how frequently it's happening. So there are a couple of new data sources. One is called Household Pulse Survey, and then there's the CDC data that they've been gathering.
Oh, household, what is it? Household
pulse, like your pulse, like that you take, right? Survey.
Okay, I'll try.
And that's capitalized, yeah. And so combining the information from the Pulse survey and from the CDC, this is what we have. So the data suggests that more than 40% of adults in the US have reported having COVID-19 in the past, at some point in the past.
40%.
40% actually identified. Now we know there are some people that think they have long COVID and may never had a defined case of positive testing, but this is,
confirmed.
Well, this is reported by what the adults say. Okay, so many of those are test confirmed. So nearly 1 in 5 of those, or 19% of those who had identified they had COVID, are still having symptoms of long COVID. And the definition they are using is symptoms lasting 3 or more months after first contracting the virus and that they didn't have prior to the virus. So not exacerbation of something previously there, but new symptoms. Huge range of symptoms, of course, because of the different, whether it's respiratory or whether it's neurologic or it's some of the other things that we've seen, cardiovascular, you name it. Older adults are less likely to have long COVID than younger adults. The category they're comparing is ages 50 to 59 compared to 80 and above. So that's a big difference, right? But, obviously the 80 and above had a much higher death rate, but those that got COVID and survived are far less likely. The age group of 50 to 59 were 3 times as high to have long COVID than the elderly. Women are more likely to have long COVID, about double male, so 9.4% versus 5.5%. Interestingly, nearly 9% of Hispanic adults currently have long COVID, which is higher than non-Hispanic whites at 7.5%, and Black population self-identified Black population 6.8%. So it's one of the few things where the Black population has a lower percentage than the Caucasian, and the non-Hispanic Asian is 3.7. So some differences also in gender identification, which is fascinating, and I don't really know what the answer is to this, but bisexual and transgender adults were more likely, they were comparable to those identifying as Caucasian, at 7.5%, but 12% of, in terms of, having long
Okay.
COVID symptoms.
Mhm.
In terms of breakdown, though, 12% of bisexual adults have current long COVID symptoms compared to 7% of those who self-identify as straight or gay.
Huh.
So that's really fascinating. I don't know what that's going to end up meaning, but it's something to be thinking
Is that
about.
real? Does it have like a p-value and all that kind of stuff?
No, because these are smaller populations and they're just percentages within this. So no, and that's why I say we need more information, but it's the
Right.
first kind of window into this. And I don't know if this is access to care. I don't know if this is, you know, the whole, I think it'll be interesting to hear Michelle's take on some of this stuff, because the perception of acceptance in healthcare, certainly transgender people have a lot of trauma with healthcare experiences and so on. And then the other thing that's really fascinating is that it differs state to state. So the highest percentage of adults who have long COVID by that definition were Kentucky at 12 and a little more than 12.5%, Alabama at 12%, Tennessee and South Dakota at 11.6%. So, and then lower were Hawaii at 4.5%.
Mhm.
I don't know if that relates to the Asian-based population there or not. Maryland at 4.7% and Virginia at 5%. So some really interesting things, I think, that we will continue to learn more about over time. But I wanted to just share that because it was in part, at least race ethnicity-based data that we finally have a little bit about long COVID. So I want to turn it over to Michelle unless somebody has a specific question. So
And we can come
Yeah.
back around to specific questions also at the end,
At the end.
after
Yeah.
Michelle takes us through her comments. So thank you for that. That was very detailed, interesting. So Michelle, you're up. Thank you for joining us today.
Oh, absolutely. Again, thank you so much for inviting me.
And you're a little soft.
Can you hear me now?
Yeah,
so
that's
thank you so
better.
much for inviting me. This is kind of a newer setup for me. I tried to use our desktop versus my laptop. So I'm a little bit, so I can see everybody on the gallery, which is a lot of fun to
Yeah.
do. So I put a reference article in the chat from the New England Journal of Medicine published in the summer of 2020 entitled Hidden in Plain Sight. So it's not behind a paywall because it's such an important article and it's been cited, over 700 times. And for the clinicians amongst us, it may be just shocking and eye-opening to have it all collated in black and white in a very prestigious medical journal to understand how we practice medicine day in and day out. So with that kind of preamble, I'm going to do a quick review of the 1619 project in 5 short paragraphs. All right. So truth, we acknowledge the past. The founding fathers were white, wealthy, Christian, cisgender, non-disabled men coming from Europe who wanted to protect their place within hierarchy while expanding an empire. The nation's history includes genocide, enslavement, and segregation of non-white people over hundreds of years. Systems of power are internalized and normalized in governments, education, businesses, and in medicine. Sorry about Milo. Patterns exist today within our institutions as norms, behaviors, and practices that are consciously or unconsciously valued, even as they disconnect us from many diverse human cultures that have built the systems that allow the United States to thrive. And these patterns are woven into the language and culture of our medical practices. So I'm going to have like 2 parts to my, short remarks. One are, what's commonly called the social determinants of health. I like to call them the social factors of health because, they exist. However, they can all be modifiable, right? So I don't want to say that once you have in a situation, that's going to be your situation. So My preferred lexicon is social factors of health that I'll run through a bit and make a few comments about that are familiar to everyone on this call. And then we'll kind of go through some of the things that are talked about in the Hidden in Plain Sight article. And then perhaps we can reflect on that and have share some of our own lived experiences, either as patients or clinicians, and how that may play out and what we could potentially do going forward as advocates for patients. So in terms of the social factors of health, education, access, and quality, right? So as a pediatrician, I don't just advocate for kids to have access to health insurance, although I do that all day, every day, and am proud to live in Washington State. Just a second. Milo, can you come here for a second? Milo.
We all have our dog. There's
a suspicious person that he is protecting me from.
Yeah.
At this moment, so I am safe and able to give this talk.
Hashtag real life.
Yeah. So education, access, and quality. So as a pediatrician, I'm going to advocate for the public schools. I'm going to advocate for free school breakfast and free school lunch for every kid. I'm going to make sure that those lunches and breakfasts are, high quality in terms of, protein, carbohydrates, and fats. And I'm going to, link nutrition to health as a very basic, foundation for health, and kind of teach kids to know that. And if kids are hungry after school, I'm going to make sure that their families, have access to the nutrition programs that help supplement them, and that, they have knowledge of the food banks around the town, because nutrition is so important to health. Healthcare and quality. All right. So I'm very proud to live in Washington State, where every child is covered by Medicaid. And when that means every child, that means children who are US born and children who are not US born. And that's a big deal, because when you look at the map of the southeastern states, they did not expand Medicaid when they had a chance. There's higher rates of poverty. And guess what? Most people of color are, disproportionately poor and do not have access to basic health. Right? I'm going to advocate for the neighborhood and the built environment. Many families are experiencing housing insecurity, and many of our neighbors are unhoused. And, land is premier in the greater Seattle area. And there's lots of discussion about how we're going to build affordable housing for a burgeoning community. And it's complicated. It's expensive to build, it's expensive to maintain. And a lot of people don't want to give up the land in there if they have a single family residence. They don't want to necessarily increase density. However, we all have to engage, especially in terms of saying, gosh, how can you, take care of someone if they're unhoused? How will they take care of themselves? I'm going to advocate for social and community context, knowing that, we're not all going to agree on everything all of the time. However, it's really important to, when we are engaging, to look forward and say, who is not at the table? Whose voice is missing? Who do we need to, ask or engage or reach out to? Folks can feel, left out if they're not approached, right? They want to have the option to say no. No one likes to feel ignored or feel that there's an afterthought. So as you're, as we're making our priorities, we need to think, oh, who's here at our meeting right now and who's not at our meeting, and how do we engage folks who aren't here with us in person or virtually. And then of course we want to advocate for economic stability, for wage earning jobs. Again, proud to live in Washington, where in the greater Seattle area, highest in the nation. Now the cost of living is high as well. However, at least we acknowledge that we can't ask people to work for free. That we value the labor of ourselves and our neighbors. And we know that people who have access to higher education usually have better health outcomes, in part because they might be employed by provides health insurance as a benefit.
I don't know if this is happening for everybody else, but you're cutting out just a teeny bit.
Oh, sorry. I'll come a little bit
Yeah.
closer. I don't know if it's our internet
Okay.
connection at all. I like go with my dog, so he might find another thing to distract us in a second. When we talk about health, we know that fewer people who have primary care physicians, die, because they have a trusting relationship with someone to say, well, when a screen is recommended, let's go ahead and do that. So hold on to the screening in a second, because we're going to talk about that in the second part of the talk. And then let's talk a little bit about the ability to understand health information. I'm dealing with a situation right now where someone very close to me didn't know what PSA meant. So when we say, whatever acronym we're talking about, CDC, PSA, BMP, BNP, these things roll off the tongues of clinicians. The patients might have no idea what you're talking about, and why would they agree to something that they don't know, what it means. It's
Oh, you're glitching out there again.
I said it's frightening to say, yes to something that you don't understand.
Well, and I think advocates who are on the line will have had lots of experiences of patients who just go along because physicians understand kind of what's next. And so people get on the conveyor belt of a certain type of care without knowing. I think you're absolutely right.
And then there's also a risk of too much medical care, as we understand, especially when there's a lateral referral, when the primary care provider refers to, say, the rheumatologist, and the rheumatologist, makes a lateral referral to the orthopedic surgeon, or vice versa. And each one is adding a layer of medications and or therapies without having a full access. And, doctors are busy, they might not go back, and even though they have access, if they have it as the EMR to care everywhere and look around, that doesn't necessarily mean they're going to do it. And so it's really important that the patient, communicates to each medical provider that they're seeing, a variety of specialists. And this medicine reconciliation is so important as well, because you have no idea what patients may or may not be taking. And as we all know, just because something is prescribed, it doesn't mean that the patient is actually taking the medication. And then, we talk about, the built environment. We talked a little bit about people who experience housing insecurity and who are unhoused. However, there's a bunch of other things in the environment that are going on. Summer or two ago, King County Medical Society partnered with Public Health Seattle King County to do lead testing. And for lead testing, isn't that something from the 60s and 70s? Is that still a problem? And yes, it still is a problem in some deteriorating housing, but it's also a problem because some of the spices that are imported from overseas that have vibrant colors are contaminated with lead, and some of the pottery and glassware that we use are also contaminated with lead. And as we know, lead is a neurotoxin, and its results are incurable, and so cumulative. So the the pediatrician in Flint, who 5 or 6 years ago sounded the alarm of lead poisoning because of the water supply in the city, was denigrated and dismissed initially when she brought it forward. So there's always, someone who's trying to protect the status quo or not admit that they've made a mistake in order to not necessarily protect the best interests of the majority of people.
And I think what you've just mentioned is really the heart and soul of what advocates do. What I was so shocked about in our prep on Friday was the information on hidden in plain sight, where from medical system and standards, race it played into, and I know you're going to get to this, race plays into evaluating and prescribing or offering certain treatments. So just race, just that. It's just so shocking. I didn't know that was going on.
We're going to go through several scenarios that are in the article, which I posted in the chat a couple minutes ago. But just kind of hold on to, a person's color is not their diagnosis.
Right.
A lot of times, a lot of people use stereotypes as a shorthand because they have to manage complex information very quickly. And so, for example, if they see an unhoused person with open wounds in the area of their veins, they might assume that that person uses drugs intravenously, and they may assume that that patient may be at increased risk for a subset of infectious diseases associated with intravenous drug use. So they kind of go down that algorithm very quickly. I'm not saying that it's a good thing or a bad thing. I'm just acknowledging that it exists. And so in that way, the way that many clinicians are taught in the professional schools is to use race as a biologic variable in place of a genetic predisposition to a particular type of reaction to medications or therapies, or race is oftentimes used as a risk factor for worsening diseases. When it's discerned, it's the racism, meaning that the person of color might not get as much face time with the provider, the person of color might not get the call back as quickly, the person of color might not get a full explanation because compared to someone else, no matter their income, also the surprising and shocking, because there might be a disproportionate people of color who are lower income. However, even in the middle class or professional class of people of color suffer racism in the healthcare system. And how can that be? And then people come forward and share their experiences, like Serena Williams, who is world-renowned, greatest of all time tennis player with lots and lots of financial resources, who complaints were dismissed during a vulnerable time while she was a patient at the time of her daughter's birth. So just one more thing about economic stability. In the United States, 1 in 10 people live in poverty. So you're going to meet them every single day, you're just walking around. And many people just can't afford everything: housing, healthy food, medicine, transportation, time off from work. One day I was talking about one day I was talking about kids in the hospital, and I can say that I check every day, even though when I'm not in service, we're at 102% at Seattle Children's right now in acute care. Many of the children, parents are, work for wage, an hourly wage. So when their kids are in the hospital, they do not get paid. And we all, kind of go to the gas pump and we say, oh, isn't that nice? Gas is expensive. But I only live 5 miles from the hospital. So even with gas being expensive, I still don't have to drive that far. And honestly, I don't have to drive at all, meaning I could carpool with someone in my neighborhood, or I could, take the light rail, or I could walk, because it's only 5 miles. I was interviewed on Como on the ice storm day. I didn't walk very far that day, but I did kind of walk a little bit and they saw me out trying to get to work. So, just, kind of be mindful as advocates when doctors make recommendations. They're making recommendations based on some algorithm or some national guideline, which doesn't take into account the economic impact to the patient necessarily. And advocates to kind of bring up and say, do you realize that the patient, had to take 2 buses, take time off from work, and it took 2 hours to get to the appointment? As you make other lateral appointments, let's kind of factor in, can all of these things be accomplished on one day if possible, versus spacing them out based on the clinic's convenience. So
can you guys talk about the example that we talked about in prep on Friday, about the discounted percentage on evaluating somebody? I can't remember if it was for diabetes, or Dale, you'll remember, Michelle.
So for the renal function and
Yeah.
I'll go
creatinine clearance and BUN
and glomerular filtration rate and how it's calculated. Sure. I can go through all of those pretty quickly, but just in terms of wrapping up the social factors of health, remember the economics of it, the neighborhood and the physical environment, the education part, the food part, the community and social context, because as people age, mainly their kids might have moved away and they may have been displaced from their neighborhood because they couldn't pay their taxes. They were, a person who, was a postal worker or, had a wage earning job and a pension. However, land, got so valuable, it priced them out of their home, and now they're in another neighborhood and they don't have the same supports that they had 20 or 30 years in their home. And then just how complicated the healthcare system is. Oh my gosh, I don't know how people figure it out. I mean, I'm in it, and I have to, do a lot of workarounds and back channels and
Advocates.
Call a friend.
Advocate. Yeah. But then you have to be able to afford the advocate, right?
Right. So it's a lot of people made friends with me when I was in primary practice. It's like, oh, I could see why you needed a friend as a pediatrician. I can really, I get it now. Someone I knew from outside of the office came into the office one time, and she sat down and she crossed her legs, and I said, what are you doing? You can't get comfortable here. You have to sit on the edge of your chair. I don't have that much time to spend with you. We can, tell me why you're here, and I'll try to address that, in this, short period of time. So I mean, and that was 15 years ago. I had no idea what it's like now. Alrighty, so moving on to the second part of our conversation very briefly. We're the human race, mapping the genome. The study of complete genomes from different parts of the world has shown that even between Africa and Europe, for example, there is not a single absolute genetic difference. That is, no single variant where all Africans have one variant and all Europeans have another one, even when recent migration is disregarded. So race is a social political construct. Making racial assumptions could be particularly inaccurate in a medical setting, and it's bad medical practice to make clinical predictions on the basis of race. It is useful to collect racial data to analyze disparities in access to services, treatments, and outcomes from a social perspective, but it's not useful to look at race from a biological perspective to determine how care is rendered in the clinical environment. And racism exists where there's an imbalance of power of social status generated by how we understand and act upon the perceived race of a person or patient. So I had this, little picture of my family, and we're all African Americans, but there's lots of information and different shape of the eyes and different textures of the hair. And so depending on the context, you could be assumed to be another race. And of course, only one race in terms of heritage. So in the South, where I'm from, if you were 1% Black, you were Black, to keep that social, political, racism hierarchy in place. So we've all heard of these, opening one-liners. A 55-year-old white man arrives into ED via ambulance with chest pain. 45-year-old Black man presents for follow-up for chronic diagnoses of hypertension and diabetes. A 30-year-old Black G3P1 presents in labor, and a 60-year-old Hispanic woman presents for her yearly physical. Notice that race is used as an identifier in the first line historically. So now our advanced medical students say, why didn't you do that? Why are you teaching that? And so we haven't taught that in the medical school probably in the last 5 to 7 years or so. However, it certainly exists and is as a central Seattle, we're seeing patients all over the state. And so that you'll see that designation in many medical charts yet. In the article Hidden in Plain Sight, feel free to pull it up in the chat. Again, it's a New England Journal of Medicine article published in the summer of 2020, but it's not behind a paywall because it's such an important article. And so I'm going to go through some of the highlights of the article where they talk about the cardiac, pulmonary, and renal. So heart failure risk score was developed by the American Heart Association to determine which hospitalized patients are at risk of dying from heart disease. The algorithm assigns 3 points to any non-Black patient. So more points mean higher risk of death. So if a white person comes in, they get 3 extra points, they're going to get more services because they got, they said, oh, this person's at greater risk of dying. So if you look at, other variables like blood pressure, diabetes, history of heart attack, family history, smoking, exercise, lipids, all the things that go into heart disease. It's like, oh, but if they're not Black, they get 3 extra points. So
this is not a medical aspect. This is just a race. I mean, that's one of the things I'm just floored by. And I think advocates advocating for their clients, no matter what race, need to think about the fact that these constructs are out there so that they dig a little deeper in advocating for their clients in medical tests and evaluation too.
But wait, there's more.
Yeah. Sadly.
Pulmonary function tests, observations about vital lung capacity showing differences attributable to height, age, sex, and occupation. Example, a typesetter versus a firefighter, were extended to include social classes and ultimately race. Whites showed greater average vital capacity for the same sex, height, and age than non-whites. A narrative of innate differences was made versus potential for environmental differences. Okay, the estimated glomerular filtration rate. The race coefficient systematically raises the estimated glomerular filtration rate by 16% for Black individuals compared to all others, conferring an estimate of better kidney function for Black individuals at the same levels of serum creatinine. Later, missed referrals negatively impact access to advanced care including potential transplant. So this has happened to me. You go to the doctor, they draw a basic metabolic panel, you get your electrolytes, urine and creatinine back, and an estimated glomerular filtration rate, which should be greater than 60 for an adult. It should be much greater than 60, but let's say, kidney function decreases as one ages. And then you get an extra 16% if you're Black, then that means your kidney function isn't as good as it should be. And then as your kidney function declines as you get older, then
Why is it like that?
Well, that's just back to the first 5 slides, the first 5 paragraphs. It's like somebody determined that was the way it should be. They took a small sample, they extrapolated, they thought that people of color were biologically different. They came up with a reason, maybe they're more muscular or something. And then it kind of got baked into an algorithm without anybody to contradict it. Because remember that, the younger generation are kind of leading the charge in terms of undoing a lot of these historical patterns. And medicine is very hierarchical. So no one was challenging the status quo. There's a lot of information to learn, and they figure that a bunch of smart people already figured it out, and that must be true. And I don't have time to question that when I have all this other stuff to learn and all of these tests to pass.
Right. And they set standards, which then, you have to have something to follow when you're looking at, labs. And so whether the standards are right or not, it's still what people have used, which is, yeah.
Right. And they don't want to be told they're wrong because they've used it for a long time, right?
Yep.
They don't want to be told that they're wrong. So vaginal birth after cesarean calculator. The calculator is based on an earlier study that found that vaginal birth after cesareans are overall more successful when women have lower body mass indexes, are white, have private health insurance, are married, among other factors. When researchers used that data to create the calculator, they removed many of the social factors, including insurance and marital status, but they included race and ethnicity as subtraction factors. So if someone has had a C-section and they say, well, I'd like to try to have a vaginal delivery and they look like me, and they plug it into a calculator that might be embedded in the EMR, and sorry, this isn't going to work, this is going to potentially be a disaster. We're just going to schedule you for a C-section. You want to be okay, and your baby wants to be okay, right? And it's yes, but not for the reason that they're that they're postulating.
Yeah. The good thing is that once that was recognized that there wasn't really great data behind it or any significant data behind it, that was basically disabled on the calculator. But there are lots and lots of areas where nothing's been done. And you always, as Michelle was saying, have to query, why is that there if there is some sort of racial thing? Some of them make sense. So if you are from Southeast Asia and you look anemic, there's a certain workup you would do because there's a high propensity of a genetic change in the hemoglobin that comes from that area. So you can't just wash out everything. You have to be always thinking, is this here for a valid reason or not? And there may be no data to help you out to say, this, if you can't get back to the crux of why it got put in there in the first place. And there's a few places where I'm sure there's a difference based on how people are perceived and how they're treated. In my realm, the risk of stillbirth is higher if you are Black or African American in the United States. And it is a fact. There's data that is behind, a lot of data that's behind it. I don't think it's because of genetics. I think it's because of how people are perceived, and it may be totally based on all the social factors that Michelle highlighted in the first part of this talk. And that's something that you want to take into account so that we are more attentive, but over time, ideally, if we balance out some of the racial, ethnic, prejudices, really biases and prejudices, and we kind of can come back around to Michelle's ideal world where all children get healthy, protein-laden breakfasts and lunch and snacks, and all children don't have to live in their mother's car, all of those kinds of things, then we will have to continually look at that and set it and make it be even. And it takes a lot of work. Actually, Michelle, it's interesting because I spent quite a bit of time this past year looking on purpose for race. Because if I was going to have to prioritize who's coming in for induction, if you're Black, I would bring you in over the white person that had the same medical stuff because I was more concerned about those things. And at some point in time, I would love to see that that's not necessary, but maybe you can talk a little bit about how you have to do extra for some of these things where there is bias.
Yeah, I mean, I think that's in the terms of equality versus equity, and
yeah,
we've probably seen, various cartoons that kind of try to illustrate that point, meaning that if English is not my preferred language, then you need to provide an interpreter for me. So that takes a little extra time. It may not be reimbursed if you're in private practice. It, is perceived to have some inconveniences. Although English is not my preferred language, I might speak some English and might understand it better than I can express. But is that okay? Is that the level of care that you would want to have? Like, oh, it's probably okay. She probably understood, of what I said, and it's going to be fine.
Mm-hmm.
So that's things that providers potentially tell.
Yeah, I'm so glad you brought that up, because yesterday when Friday in prep, I think that's one of the things that's so, like, even for advocates, we make assumptions that everyone understands what we're saying, and so the whole interpretation piece to me is really critical for advocates. So thank you.
Yes, this speaking in the patient's preferred language, doesn't speak English, doesn't limited English proficiency. It's like they may speak 5 languages, but English is not the preferred language for care. And in order to have a detailed understanding and thoughtful discussion, an interpreter is for our conversations, and a professional interpreter, not the patient's child, not the patient's spouse.
Yeah. Hey, Seema, I see that you just posted dividedwefall.org. Can you say what that was?
That's the cartoon, one of the cartoons that I've seen that Michelle was referring to, that shows a cartoon that shows equality versus equity.
Mm-hmm. Right.
Gotcha. Okay, that's great. We'll include that in the resources from this call. And Rachel Westlake, you posted the Black OBGYN project. Rachel, are you there?
Sorry, I was talking.
Go ahead.
The wrong button on. That I started following Black OBGYN project on Instagram about 2 years ago, and there's just a lot of resources. They're mostly, they don't have a website, but it's about increasing inclusion in education and OBGYN education and stuff like that. And there's just all kinds of resources linked to them. So I just thought I'd throw it on there.
Great. Thank you so much. And I would say, we have a few more minutes. So if there's anybody who has additional resources, betterbikeshare.org. If you could throw them in on the chat, that would be great. And if you have any final questions for Michelle or Dale before we wrap up, that would be great as well. I think, Michelle, one of the things that I wonder about is is there any way or any central resource for challenging whatever it is for clients that they're getting in terms of either treatment or diagnosis or anything like that that advocates should be looking out for?
Yeah, I would probably suggest approaching it from a perspective of curiosity, saying, oh, you made the recommendations for this treatment or that treatment or wait and watch or whatever, the situation is. And it's like, are those from published guidelines or from your clinical experience, opinions? I mean, you just want to know where it's coming from. And if, for example, it's coming from an NIH guideline for breast cancer, which kind of, estimates risk of developing disease is lower for Black or Latin people, then you can say, oh, did you realize that, this calculator is programmed with some flaws? And so like taking away the race cofactor, does that change your recommendation?
Right.
Some interesting things are coming up in the state legislature, which is in session now. I was looking at a bill that is going to kind of modernize the pre-authorization process. So that's not a delay and denial for patients because some treatments are well established and are not experimental. However, by the time a provider does all of the paperwork, everyone's kind of got lost interest in pursuing their treatment. And so I'm not as good treatment like student, again thinking that it's okay, which is not okay.
Right.
So that's something to kind of keep your eye on, as well as anything in the that touches kids, and families, and support all of the social factors and health that can help improve health and actually save money.
Is there any central kind of like watchdog resource that basically keeps tabs or marks kind of all the various different ways that racial discounting in the medical system is done? That would be a resource for advocates.
I think this seminal article, Hidden in Plain Sight, is helpful, and it's been cited over 700 times. So I'm sure there's lots of other articles that have branched off from that in the last couple of years. Many medical students are writing perspective pieces for the medical journals talking about their lived experience. And I think that changed for me in the last 3 years of COVID, whereas before I just was interested in data. I was just interested in kind of what the randomized control published trials said. I wasn't as interested as a person's lived experience, which I discounted as an anecdote. I've done a 180-degree turn on that, where I want to hear all of the lived experiences. I want to hear what happened and how we can make the experience better.
Yeah, that's great. Really awesome discussion, and also appreciate everybody's joining in terms of resources. Somebody asked if we'll be sending that around to people participating in this call, and I will do that. So I think it'll be pretty easy to do. So look for that in your email today. And just any final comments, Michelle and Dale, on this topic. So important, really learned a lot. So appreciate it.
Yeah, I think Michelle's point about curiosity is really it. What's this based on? I mean, I think that's an advocate approach to healthcare anyway, and doing it for someone else as well as for yourself. It's actually harder to do for yourself, I think, in some respects, than being available to help someone else ask those questions. What's this result or recommendation based on? And what if And if they say it's based on what's published by the lab, then what if that's different? What would your recommendation be? What alternatives are there? And one thing that hasn't been said is that we know that people who have had negative healthcare experiences during their life are hesitant to enter into healthcare. They may not be the people who can afford a formal advocate. And so educating the public on how to be their own or their family's advocate, I think, is a really important thing to think about as we move forward.
And Michelle, you get the last word. We're right at noon, but you get the
Oh,
last word.
Well, thank you for inviting me. One of my little taglines is like, people move at the speed of trust, right? So in trying to have a trusting therapeutic relationship,
Yes,
it might not happen in one visit.
absolutely. And I'm just so grateful for you. Thank you so much for spending this important day with us. And thank you to all the advocates from HealthAdvocateX. We're looking forward to a great 2023. And if you haven't already, send an email to info@healthadvocatex.org for case review. Professional case review is going to be really interesting this Thursday at 4 p.m. Pacific. It's about when patients don't choose best medical advice or care, and how you navigate that as the person's advocate. It should be really great. Presented by Chris Price. So you sign up if you're a member. It's a member benefit by emailing info@healthadvocatex.org. So look forward to seeing you then. And thanks so much, Michelle, Dale, Beth, and
Yeah,
everybody
thank you
else.
guys. Yeah.
Great discussion.
Happy MLK Day.
Happy MLK Day. Thank you all. Have a wonderful day.
Bye-bye.
Bye.